Just a reminder that these webinars are done for educational purposes only and are not a substitute for medical advice. Talk to your medical team if you have any questions or concerns about your individual care or treatment. Remember that we all have our own opinions, and these are our own opinions. They do not necessarily represent the opinions of LACNETS. We also recognize that we are all zebras, and each person's situation is unique. A reminder also that the videos will be posted on YouTube later next week, so if you want to rewatch the videos, you can. So now we'll go to our live Q&A. Well, welcome to our live Q&A. We're really excited to have Dr. Dan Lee, Dr. Sandy Kotiah, and Dr. Del Rivero. So Dr. Sandy Kotiah is board-certified medical oncologist and hematologist and serves as the director of the Neuroendocrine Tumor Center at Mercy Medical Center in Baltimore, Maryland. Dr. Dan Lee is assistant clinical professor in the Department of Medical Oncology and Therapeutics of Research at City of Hope, specializing in GI oncology, and is the co-director of the Neuroendocrine Tumor Program at City of Hope. He's involved in several committees, including research committees for NET, the Professional Medical Net Society, and has authored several publications in peer-reviewed literature. And Dr. Jaydira Heidi Del Rivero is board certified in both endocrinology and medical oncology, and she joins us from the NIH. She currently has efforts going on underway with open clinical trials that are really exciting, as we have all already heard. So welcome to the three of you. Thank you for joining us today to honor NET Cancer Day with this educational symposium. And so we'll dive right in. And the first question that we have is, how do we find current research literature, and how can we find information on current clinical trials? And I'll give that to you, Dr. Lee.
Thanks, Lisa. Yeah, so I think this question is kind of twofold in terms of how to find NET literature. I would say one of the first things that, just like you do for anything that you're looking for, you can go to good old Google and kind of Google a topic that you might be interested in. But that's kind of a general broad search that you would do at first. And then once you identify that broad search and there's a specific topic that you want to look at, then usually we go to the primary literature, usually on PubMed. So I think Lisa can put up a link in terms of, how to, the web address for going to essentially PubMed. And there you can type in a specific investigator's name, or you can type in a specific article that you're looking for, or just a general topic for neuroendocrine tumors. And then you'll get a list of various different publications that has been shown. So that's how you would look at some of the research aspect of it. In terms of looking for clinical trials, clinicaltrials.gov is an excellent initial source to go to see the various different types of neuroendocrine tumor trials that are available. Usually that's a fairly long list, and clinicaltrials.gov will update periodically in terms of what are the trials that are active and that might not be inactive or have completed accrual. So it's really important to go to that website, see what potential trials are available, and then bring it back to your NET provider and have that discussion, because usually your NET provider will have a little bit more insight in terms of what are the key trials that are still active and ongoing, and maybe also insight in terms of what types of trials have already completed accrual.
Great, thank you. And a follow-up question to that, I guess we'll start with you, Dr. Del Rivero. I know you already addressed some of the current trials you have open, but how many current clinical trials are there for NETs? And,
yes.
of those, which one or ones are you most excited about?
Thank you so much, Lisa, and thank you so much for having me here today. And that's a great question. I think it's important that we, first of all, educate our patients as well for any possible neuroendocrine tumors that is out there. But one thing that I usually recommend to our patients is to go to clinicaltrials.gov. So you can Google that, and then basically in those situations on that website, you can type always the tumor type and even which area you're from, because there are clinical trials all around the country. And I think that you can always type the region that you are closer to. You can also type the type of tumors, and then there are different trials that also appears on that clinicaltrials.gov. there are current various trials and ongoing and upcoming clinical trials. And I think Dr. Lee and Dr. Kotiah can also comment on that. But the way I like to kind of like describe these different clinical trials available for neuroendocrine tumors are the ones that are for the well-differentiated neuroendocrine tumors. And there are up and now various clinical trials. We have the cabozantinib study. Jennifer Chan from Dana-Farber has that study. We have the study available also for PRRT in combination with triapine. Dr. Aman Shahan is a PI on the study. I believe Dr. Lee is also a PI on his, and maybe he can comment a little bit about that. I am very excited about this trial because as we discussed earlier on the discussions, we know that PRRT or Lutathera is effective. However, we wanted to make this therapy even more efficacious in order to shrink the tumor. And I think that's where we have these combinations, treatments with Lutathera. We have the triapine, the other ones that are coming as well. And also UCSF has also Lutathera in combination with immunotherapy. There are also other trials for the higher grade neuroendocrine tumors, and Dr. Jennifer Eads has her trial as well in combination with chemotherapy. But I think that it's important that, and it's always something that I advise to my patients to go to clinicaltrials.gov, look at the region that is closer, and then after that, I'll also look at the tumor type as well. I think that's important. I don't know what Dr. Lee has or Dr. Kotiah has any other thoughts about that.
Thank you. Let's go to you, Dr. Lee.
Sure. No, I absolutely agree with Dr. Del Rivero. I think it's really important to kind of break down the clinical trials based off of what kind of patients that the clinical trial is specifically trying to help. So for the well-differentiated trial or for the well-differentiated neuroendocrine tumors, I completely agree with Dr. Del Rivero. I think cabozantinib for patients with a well-differentiated neuroendocrine tumor is probably furthest along in terms of development. And I think the Alliance Cooperative Group, after some initial resistance, have finally understood kind of the challenges with accruing to that trial. As I mentioned in my talk, it was a randomized phase 3 trial versus placebo. And I think that wasn't relatively fair to the participants going on to the trial. So they're going to have an amendment which will allow for crossover for the placebo group to get the experimental treatment of cabozantinib at the time of progression. And I think that would be very meaningful to patients. I think for the poorly differentiated high-grade neuroendocrine carcinomas, I think this is really an unmet need. And I think one of the very interesting trials, and we have a lot of hope for this trial, is the triplet therapy trial with cabozantinib plus nivolumab plus ipilimumab. Mm-hmm. I think a lot of us who treat this disease have already seen some initial signals with nivolumab plus ipilimumab from the SWOG DART trial and everything. And so this would really, kind of build upon that. And it's an earlier phase trial, so everyone gets the experimental treatments. So that's very beneficial for a high, very aggressive type of tumor. So I think that's a very important trial. And as Dr. Del Rivero mentioned as well, in terms of PRT, I think there's various different types of PRT trials that are looking at kind of combination treatments. We recently opened up, Dr. Chahan's trial with, triopan plus PRT, like Dr. Del Rivero mentioned. And then finally, I agree, paragangliomas, pheochromocytomas is oftentimes unmet need and everything. And I was, very encouraged, to see Dr. Del Rivero's trial mentioned at the Alliance Cooperative Group meeting just yesterday, where she's looking at temozolomide plus olaparib. I think the mechanism of action is very interesting in terms of the synergy of the two compounds. And we know that temozolomide does have activity for paragangliomas. It's something that we tend to use a lot and everything. So I think that trial is going to really be able to build upon what we already know and potentially really improve patient outcomes for that rare subset.
Okay. Thank you, Dr. Lin. And something that I would like to add also for our NET patients is that I think that now there are more awareness about neuroendocrine tumors, and now the different cooperative group, which is part of the National Cancer Clinical Trials Network. And that's what Dr. Lee was saying is the Alliance, the ECOG, ACRIN, the SWOG, they're all part of the NCTN, which is the National Cancer Trials Network. And I think there is more awareness as well about these neuroendocrine tumors. And there are definitely more trials upcoming for neuroendocrine tumors. I think it's an exciting time too. I think Dr. Kotiah and Dr. Lee, you agree with me, because I think we're making more and more efforts to definitely, develop more treatment options for neuroendocrine tumors.
Yes.
Yeah, I just want to make one comment, which is that, I have clinical trials that I have been opening and open at my center as well. And, I think let's not forget that when you're looking for a clinical trial, it's because you've exhausted the standard of care and, you have gotten what we think works and what has shown, benefit, and now it's no longer working. So you're reaching for something that is experimental, but for us, I think as neuroendocrine providers, we're kind of excited about looking at combination therapies and seeing if we can improve response rates and improve survival and capture more patients. Because even though PRRT has been, I think, revolutionary to the field of cancer in general, the fact that we can do targeted radiation and use a marker specific to the cancer to find the cancer to try to target radiation to it. I mean, I know that there's other cancers that we're looking at that technology for biotheranostics, but the response rates haven't been as great as we wanted, which is why we're trying to improve on it and try to combine things. And we're trying to make sure that there's not toxicity involved, but that there's going to be more benefit than toxicity. So I think that, I wouldn't always jump to a clinical trial, especially if you're newly diagnosed patients, because there are a lot of standard treatments that you can get that can work very well for a very long period of time. But I do think that there are plenty of patients that have exhausted the standard of care and they're feeling great and they still look good. And we really want to be able to offer them more treatment options. So I think it's very exciting that we have all these trials and that we have all these investigators who are opening trials like Dr. Lee and Dr. Del Rivero.
Right.
I think that.
Yeah, I think just to add on to that, I think really work with your provider. I think as what Mary highlighted in her testimonial is that this is kind of a strategy that you want to work together with your provider because there's different approaches for different patients. For some patients, they might want to see a lot more of the data before they go on a clinical trial, and therefore they might wait for a later trial once they've exhausted kind of traditional therapies. But then there are other patients who want to potentially broaden all the different lines of therapy that they might be able to have throughout their neuroendocrine tumor journey. So they might want to go on a clinical trial relatively early when there's still FDA-approved treatment that's already available that they can go on to at any time later on. So I would really say that, you have to build this kind of teamwork strategy with your provider and kind of really be able to trust each other in terms of when to, pick the timing of the trial, because clinical trials will come and go. Just because one trial is available right now doesn't necessarily mean that a trial is going to be available, let's say, 6 months or even 1 year or 2 years from now and everything. So you want to be able to take advantages of the timing of the trial as well as your overall outcomes that you're trying to achieve.
Right. That's a good point, Dan, because there are trials for newly diagnosed patients and we don't want them to necessarily pass up on them. That's a good point.
Great. I think the exciting thing for the NET patient community is that there are clinical trials, right? So that, the graph that Dr. Del Rivero you showed in your talk, there's all these treatments that have come out in the last several years and more. And also when we hear that there's more work being done, just to hear that all this stuff is going on behind the scenes is very encouraging. Right. So thank you all for that. I guess another practical question that I is not submitted, but I just wanted to ask the follow-up because this comes up in our support groups is, what about the financial aspects of it, right? Especially if someone's HMO, can they qualify for a clinical trial? And how do they go about doing that? And Dr. Del Rivero, we'll start with you.
I will, if it is okay, I would like to pass on in Dr. Lee and Dr. Kotiah, since I am in a research institution, so I don't necessarily, exposure with insurance companies. So that's why, if it is okay with Dr. Lee and Dr. Kotiah, and I can always chime in.
Sure, absolutely. I can take this one. And I think it really depends on, I think that there's potential, state to state variations. So I can comment in terms of what happens here in California. So in California, every single person, there's a law that essentially mandates that every single patient has a right to access to clinical trial, irregardless of insurance. So what that means is that when you see a provider and you consent to a clinical trial, that institution will submit for authorization to the insurance. And it's almost very difficult for an insurance company to potentially deny it because of that state law. The only instances where that's even potentially possible are certain insurances where to the patient, they have a pre-identified clause within their insurance that says this does not apply to clinical trials and everything. But those are really like outdated, documents and everything, and it's very, 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 very rare on that occasion. So at least in California, we're very fortunate that because of the law that's in place, that anyone that wants to be and wants to participate on a clinical trial, they will have access to that clinical trial, and it will be covered, for insurance. So financially, it is not a significant impact. Now, you could have, potentially Medicare insurance where if you don't have a supplemental, Medicare will, cover, let's say 80% and everything, and you're, on the hook for potentially 20%. So there could be instances in those scenarios and everything. So again, it's very good to, work with your insurance companies and everything to make sure that you're able to, do everything properly. And usually wherever you're going for a clinical trial, again, the financial counselors of that institution is going to be working with your insurance. So very rarely would you be actually getting a bill for anything that's done on a clinical trial.
So that's not really what happens in Baltimore, unfortunately. So there's that, and that's great, Dan. I wish maybe I should move there. But there's of course like industry sponsored trials, and then there's government sponsored trials that we have access to at our institution. With the government sponsored trials, there's not as much funding, although that doesn't mean that trial is not important. It's extremely important, but the funding is not always there. But the industry sponsored trials, the pharmaceutical company that's funding the trial, usually takes up the cost of whatever extra lab work, extra imaging that needs, and of course the drug cost. They make sure that is not a cost for the patient. For the government-sponsored trials, I've gotten pushback on the imaging because they want imaging, of course, every 6 weeks instead of every 2 to 3 months. And sometimes I've gotten, denials about blood work. So it's much harder for us to have government-sponsored trials at our institution. I wish it was a little bit easier, but that is a concern for us. And that, usually there's not a shortage of trials. JD is not that far away from me, and I can always send them to NIH if I need to. So I haven't felt the lack because of that, but that's definitely something concerning about, getting reimbursement for the patients for insurance and having to fight with them for the government-sponsored trials.
And just to add information here, I work at the National Institute of Health, so we are a government-funded research facility. And because of that, we are not dealing directly with insurance. I have to say that the NIH and the NCI has recognized the need to study more rare tumors, especially neuroendocrine tumors. I think they have recognized there is a need, there is a significantly unmet need, and that's why they are realizing that, okay, we need to invest on this disease, we need to develop more effective treatment options. So I think I'm very fortunate to be where I am right now because I feel very lucky to be helping with these efforts as well. But everything that we do at the NIH is free of cost. So in regards to lab, CT scans, lab, drug, everything is free of cost, and we don't involve the insurance for any kind of payments. The only way that we can involve an insurance company is, like, for example, if we need any form of transportation from one way to another, like they require a different specialty care that we may not necessarily have at the NIH. But other than that, in terms of follow-ups, care, we even fund for any travel because we see patients from all over the United States. We actually, depending on the trial, we can fund any travel back and forth as well. So I think that's, and again, I feel fortunate that I think the NIH has recognized that this is an unmet need, the field of neuroendocrine tumors.
Right. Thanks for that. And that's our tax dollars at work, right?
Yes, that's correct.
There's a specific question for you, Dr. Del Rivero, about your natural history study. Specifically, does it include sexual orientation in the demographic study?
So yes, so the NIH, we include any, I don't think we include all patients, regardless of the age, regardless of the race, regardless of the sexual orientation, regardless of, where they're from. I think that we are very inclusive. I think the NIH is something that our clinical director, Dr. Francis Collis, definitely wants to recognize, like the whole kind of like we are one unity. We need to collaborate. We need to really be together. He really trying to, something that I've been proud of the NIH, we have a lot of diversity, and they're very, we see a lot of that in my institutions. I have to say that in our natural history study, we include everyone, regardless of where they are from, where they are, from all over the world. So I think this is a unique opportunity to really, see these patients and really understand more about the disease in a more organized, systematic way to study these tumors.
Okay, great. I realize I misread the question. It says, does the natural history study demographic questions include sexual orientation? So
yes, I mean, we wanted to include all of that. Yeah.
Great. Okay. Let's move on to some questions about symptoms, because, living with the disease, of course, is really a challenge. And so a question that comes up is, how is carcinoid syndrome diagnosed? And we'll start with you, Dr. Kotiah. How is carcinoid syndrome diagnosed? Does the patient have to recognize or report long-term symptoms as abnormal, or is it automatically tested for?
Yeah, well, that's a good question. So, most people do not have carcinoid syndrome, but a lot of people have diarrhea. Mm-hmm. So when I see a patient who comes in with a neuroendocrine tumor of the small bowel, or, where you classically find where you're going to be looking for carcinoid syndrome, and they have liver metastases, which is most of the cases they have liver metastasis, I usually check a 5-HIAA level. And if they're describing, some of them flush right in front of me, and I'm like, wow, that's impressive. And you can just, you can expect that their 5-HIAA is going to be elevated. But especially if they're describing, the flushing and the diarrhea, and the diarrhea is waking them up at night, so clinically it makes sense. And then you can confirm it with biochemical testing and drawing the 5-HIAA level.
Mm-hmm.
Okay. And Dr. Lee, do you have anything else to add to that?
Oh, I agree.
Yeah.
Okay. Dr. Del Rivero?
Yeah, I think I agree with Dr. Kotiah. I think when we have the suspicion that this could be neuroendocrine tumor, the urine test is very important. I know that there are other markers like chromogranin A, but chromogranin A is not a specific marker, and not everyone uses chromogranin A. But again, I think every institution has difference in opinions about using chromogranin A, at least as a biomarker, responsive biomarker. But one thing that we do when we have, in order to diagnose somebody that has either carcinoid tumor, then after we have the biochemical evaluation with a urine test or a blood test, then we do the imaging studies as well. And then the imaging studies could be either from CT, MRI, to these more Gallium scans that is more specific for neuroendocrine tumors.
Great. So a related question is it possible to continue having carcinoid syndrome after the primary has been removed, especially something like lung, and nothing else visible on the scans? So we'll start with you again, Dr. Kotiah.
Well, that's the challenging thing, because I think I've met patients who are convinced that they still have carcinoid syndrome, even after they've had definitive surgery and the 5-HIAA levels are normal. And it's really hard for me to sort of imagine that's what's causing their symptoms. I know that sounds kind of awful, because a lot of people are convinced that they still have it. And sometimes it gets to the point where I do a trial of sandostatin or short-acting subcutaneous just to see if their symptoms get better. And most of the time it doesn't change. So, I think there are a lot of, I know we're always saying, hey, when you have flushing and diarrhea, don't forget that there's neuroendocrine tumors out there. And that's true. But sometimes people can have diarrhea and flushing for other reasons, and not necessarily neuroendocrine tumor. Is all I'm going to say about that. I'm going to leave it to my colleagues to kind of chime in if they want to.
So we'll go to Dr. Lee and then Dr. Del Rivero.
Oh, yeah, no, I completely agree. This is a challenging aspect. And, I think uh, testing it with kind of somatostatin analog therapy for someone who has, let's say, persistent symptoms, but not necessarily any evidence of disease, you can see, and you can see whether or not there's an impact. I agree. If there's no response to that, then I think you're relatively pretty clear that it's not due to it. The harder question is, what if you do feel better? What do you do? And I think, again, you're going to have a very detailed discussion and very frank discussion with your provider, because as providers, we really try to focus on the science, and really try to say what we believe might be the potential causes from what we know, as far as we know from the science and everything. But at the same time, we also know potentially what you're feeling and everything. And I think it's potentially okay for a provider to just say to you, I don't necessarily know why you have those symptoms, because that's the truth and everything. But how do we work together to manage your symptoms, and whether or not there's an effect? Because no matter how benign somatostatin analog therapy is, there's still side effects that's associated. There's still long-term impacts that's associated with that. So you have to have that risk-benefit discussion with your provider, and an honest discussion in the setting of the unknown.
For that. And Dr. Del Rivero?
Yes, thank you. I think it is an important question, and I usually like to add to this, and I'll tell you why. When I was a practicing endocrinologist, I got a lot of consults, like it was flushing and diarrhea, rule out carcinoid syndrome. I got a lot of consults as a practicing endocrinologist. And that's one of the reasons why, when I was an endocrinologist and seeing more of these patients, I decided, if I really want to treat these patients from every aspect, I think I want to go back and do more training, so that way I can, treat the more advanced disease, because I was getting a lot of these consults. I remember when I was in New York as a practicing endocrinologist, and it's true. I think I do agree with Dr. Kotiah and Dr. Lee, and it's true. Like Dr. Kotiah say, I don't think this is your neuroendocrine tumor. Maybe another reason why you have this flushing, or maybe why you have these diarrheas. Sometimes when they have any abdominal surgery, sometimes, as a complication, they can also have the continuous diarrhea because of the abdominal surgery that they have, not necessarily related to the neuroendocrine tumor. And sometimes with the flushing, sometimes I found that there may be other abnormalities associated with the flushing, like having menopause, like having thyroid disorders. So that's something that I was finding in a lot of my patients. I do think that I do feel like we don't necessarily need to ignore it. I do feel like you need to work very closely with your physician to say, well, we don't see any evidence of tumors. There may be something else that may be causing this. And maybe have a hormonal evaluation to determine if maybe the lack of testosterone or the lack of estrogen is causing those symptoms. And maybe the diarrhea may not be necessarily because you have a tumor, maybe because of the complications from the surgeries. So those are the things that, kind of like explain my patient. But that's a good question. Thank you.
Yeah. Yes. Thank you for that really thorough answer. And, this is a related question. It may be the same person, but let's take a case, right? So if someone has known carcinoid tumors that were removed at an early age, like 7 years old, and then they later on had return of symptoms years later, but their gallium-68 scans are negative despite multiple gallium-68, they're normal, and they respond to SSAs, but those SSAs only last for 2.5 weeks. Number one, what other diagnostic or genetic testing would you do if that gallium-68 is repeatedly normal? And number two, what would you do to keep controlling the symptoms? So Dr. Del Rivero, would you like to take that one?
Yes. Can you repeat again about when was diagnosed with neuroendocrine tumors? It was 7 years ago? Or
the at the age of 7.
At the age of 7 years old. Oh, okay. So that's very, very young. So that's a great question. And I think that something that, I mean, and I can tell you by my experience that I have acquired at the NIH, but yes. So one thing, when I see somebody, very young patients, and we're seeing more and more of those patients as well, but when I see somebody that is that young, one thing that I need to evaluate is for any cancer predisposition syndrome. So that's something that we do. Sometimes in our study, we do a very comprehensive molecular analysis on the tumor. And sometimes the tumor, if there's any mutations within the tumor, that sometimes guide us to do what specific genomic panel we can do, germline panel. But something that we look in somebody that young with the neuroendocrine tumors is to look for other cancer predisposition syndrome. And which one are those? Multiple endocrine neoplasia type 1, bone hypolando, neurofibromatosis, tuberous sclerosis. So those are the other cancer predisposition syndromes. And I can tell you that I have seen similar case in somebody that has multiple endocrine neoplasia, that sometimes they remove the tumor, but then years later may have they have presented with the symptoms again. And the thing is, like multiple endocrine neoplasia, they can have different neuroendocrine tumors. They can have a lung or a thymic carcinoid. They can have pancreatic neuroendocrine tumors. They can also have small bowel neuroendocrine tumors. They can also have carcinoid. So those are the things I need to look in somebody who presented that young to determine if that panel was done, at least to rule it out. One other thing, and that's something because we have the experience at the NIH, is about familial carcinoid. So familial carcinoid is when we see 2 or 3 family members that had the history of having carcinoid. And sometimes those familial carcinoids are very difficult to diagnose. They're very small, they're very multiple, very close to the nearby area. Sometimes they can cause symptoms, but sometimes very difficult to localize. And surprisingly, this is something that Steve Wong at the NIH has worked on that. It seems that the Gallium scan, sometimes they don't detect the tumors. As we know, there is a specific scan called F-DOPA scan, which is only in research institutions. It's not approved by the FDA. I think it was recently approved for Parkinson's disease, but it's not necessarily approved for neuroendocrine tumors. So that's a difficulty, and so it's not widely available. But that's something that Dr. Wong and our institution has been able to diagnose, and he feels that this is a better scan compared to other imaging studies. But that's, one thing. I think those are the things that somebody that young is to determine if there is any family predisposition syndrome. And now, in regards, I wanted to answer like the second part of the question is like, well, I've been on Lanreotide. It helps me, but then it lasts for like 2 weeks. And I also would like to know your thoughts of Dr. Lee and Dr. Kotiah. Like, what is their approach? How do they help control? Because I do have that with my patients that may last. It helps, but they may only last for like 2 weeks and then after that they start having the symptoms again. What do we do? And instead of 4 weeks, can we do it the long-acting Lanreotide azacitidine every 2 weeks, every 3 weeks? How about the short-acting? When do we use that? How about the new pills? I don't have a lot of experience with the octreotide capsule extended release, but I know that was just recently approved, and that's something that I think they has been using for some neuroendocrine tumors. I personally don't have experience. I would like to know Dr. Lee and Dr. Kotiah's experience about the capsule on actin, but it seems that they wanted to use more like a rescue shots, and that's something that can be used in between the long acting as well to help control the symptoms. What do you think, Dr. Lee and Dr. Kotiah, about that?
I mean, I was going to say, you
go ahead. Go ahead. No, go ahead.
No, I was going to say, I think Dr. Lee kind of addressed, this dilemma that we get into where somebody has normal hormone levels, normal scans, and then you've done a trial somatostatin analog and they feel dramatically better. I mean, am I going to sit here and pontificate that we know how to measure all the hormone levels that neuroendocrine tumors make and we know how to, track them? No. I mean, there's hormones that are being made that we don't have the technology yet to sort of check or to really be aware. Right. I think the problem lies in that if somebody's young and you're giving them, these injections for symptom control, and, we're not talking about tumor control because you can't find any tumor anywhere, they're likely going to run into problems with developing diabetes on the drug and pancreatic insufficiency on the drug. And it's like Dan said, it's not a benign thing to put somebody on somatostatin analog. And it's a very sort of dicey situation because you don't have measurable disease. You don't have a way of knowing for sure that somebody has hormones, and you're just treating them blindly. And I think it puts a lot of, pressure. Like, you don't want to do harm to that person. And you know that if they continue to take that drug, they will get side effects, or they will get toxicity. They will become diabetic potentially. And that's hard for me. Like, I think it's a lot of back and forth. I mean, I know our technology is not there, but are there other ways to manage the person's symptoms without intensifying somatostatin analog? I mean, I know there's new data now with lanreotide. You can give it every 2 weeks potentially for tumor control. I'm sure that's going to translate eventually to, like, for symptom management. But, and then we have Zermello, we have the Benfezia pens, and we have, these new, we have ways of, like, helping people with breakthrough symptoms try to get better control. But specifically for that patient, it's very challenging for me, because I would feel the balance of toxicity versus benefit. Where are we, and how bad are their symptoms? Are other things able to be done to manage their symptoms? Dr. Lee, I don't know if you have any other thoughts.
Yeah, no, I completely agree with your comments. I think, again, this comes down to an individualized approach, and just like everything in medicine right now, kind of weighing the potential risks and benefits, and what are your goals of treatment with any of those treatments. Unfortunately, in medicine, no matter how many advances that we have made, none of the treatments in medicine, this is not just in oncology, but overall in medicine, none of the treatments is completely benign. You could be taking a medication, let's say for constipation, for example, lifelong constipation, not related to your tumor or anything like that. There's a potential side effect with that medication over time. So you have to understand that everything comes at a risk, and what are you trying to achieve and everything. You could say that, I can't live my life on a daily basis unless I have the injection in my system and everything. And I'm willing to incur the risks that might come, even if they're relatively small. I'm willing to incur that risk so that I feel better for the short time and everything. So here, you're going to value that more than the long-term risk. And that if that's your value, then it makes sense. But if you say, the symptoms are really not that bad, I can probably tolerate it. I don't have the best quality of life, but I have an okay quality of life. And by not taking it, I'm going to potentially minimize my risk to other things. And now that's a different story in terms of how you prioritize. So this is really kind of an area of research that we're looking at. We had a NIH grant with this, looking at kind of patient preferences for competing outcomes. And hopefully we'll be able to, in the near future, share some of that data to really see, how our neuroendocrine patients, kind of prioritize these, potential competing health outcomes, because I think that's ultimately what's needed to make a lot of these decisions.
That's a really good point, right? It's a risk-benefit analysis, and always a conversation with your doctors. And speaking of conversations, actually, there was a really good question that came up about communication with the doctors. Let's see if I can find it. So patients specifically said, I have trouble answering the question, what is your pain level? So can you come up with some way to help me communicate this that would be helpful? Dr. Lee, would you like to start with that?
Oh, so yeah, so pain is very hard to quantify, right? I think, my pain threshold compared to everyone else's pain threshold might be very different, right? Like I think I can tolerate a lot of pain. So I'm not gonna ever rate my pain as really, really, really bad until it's really, really, really bad. Probably my, let's say, if I rate a pain on a scale of 1 to 10, which is traditionally what you get asked in the clinic, I might rate myself as a 3, but Lisa, you might rate yourself as a 9 and everything, and we might actually have kind of very similar pain and everything like that. So it's very individualized. It's very perspective. There are kind of like different scales to kind of measure these things. There's kind of a happy face scale where it shows you like how bad your pain is, and you can see it in that way and everything. But I think rather than focusing on what the actual number is, it's really to, kind of bring it back in terms of relating it to like, how is that compared to your normal day-to-day? And like, how is that, let's say, compared to like what you have known, previously and everything. So it's essentially quantifying it relative to your baseline rather than quantifying it to everyone else's baseline.
I mean, I agree. And I think, so every time a patient tells me about a symptom, and I've been following them for some years, like shortness of breath or pain or whatever, I'm like, is it better, worse, or the same as the last time I saw you? And do you need me to do something about it? How, do you need me to interfere? Is it bothering you enough that we need to look into it more, or give you some medication for it? Or, that's how I sort of gauge symptoms in my patient.
Okay.
Yeah.
Thank you. That's really helpful, right? In really basic patient layman's terms, right? Is it better, worse? What can I do for you today?
Mm-hmm.
Dr. Del Rivero, did you have anything to add to that?
No. I think that was covered. Thank you.
Okay. Another question that comes up often surrounds diet and how it might impact NET. And specifically, there was one that came up about if a vegetarian diet might affect one's immune response. And could it lower your blood counts, your white blood cell counts, your red blood cell counts, enough that we need to consider this when taking treatments like everolimus or PRRT? Dr. Lee, let's start with you.
So I'm curious in terms of what the others on the panel would say. I mean, I don't believe we have necessarily evidence to indicate that. So I don't think that right now we have enough data to say that diet can potentially make a huge change on a consistent, durable basis in terms of hematological variations, whether it's white blood cell count, red blood cell count, platelets, and everything. Usually that's more impacted due to either other medications that you might be taking. Like medications is probably the number one cause of other medications in terms of impacting things like white blood cell count, whatnot. You can get a lot of variations in terms of the white blood cell count from day to day, just because how we measure the white blood cell count, and it's kind of complicated for me to kind of get into. You just have to kind of trust me in terms of how we test the white blood cell count. Right now, it's not like so precise, so that's why you're going to get a lot of variations kind of from day to day. So specifically with diets, I don't believe that there's enough evidence right now to suggest that can have an impact on kind of blood counts for a durable period of time.
Okay, so Dr. Kotiah, if a patient is on everolimus or PRT and all of a sudden decides to change to vegetarian and their counts drop, could it have been from their diet?
I mean, I agree with Dr. Lee. I mean, so we make white blood cells, they turn over every 3 to 24 hours. They turn over very quickly, right? That's why when you give chemotherapy, you give therapy, that's the white cell, that's the blood count that's going to go down the quickest and recover the quickest. I have had patients in the last 10 years that I've been at Mercy, who are, meat eaters, vegetarians, vegan. I have never noticed a trend that my vegetarian or vegan patients have lower white counts than my patients who eat meat, although everybody sort of acknowledges that, cheese and meat can be inflammatory type of foods. I think that the cancer guidelines are sort of very strict about how to prevent cancer or try to decrease your recurrence, in that they say that you should eat a plant-based diet and no processed meat, or eat meat very little, and exercise 2.5 hours a week, moderate intensity, and all those things that they recommend. So we don't want people to be like, well, I can't be vegetarian or I shouldn't be plant-based because somehow it's going to drop my white cell. It's going to impact my ability to tolerate treatments. I mean, we expect people to have, blood counts that drop on PRRT or on everolimus, and we have ways of adjusting for that so that patients can stay on treatment. That's sort of my spiel on it. Dr. Del Rivero, if you have anything.
Yeah, no, I agree with you and Dr. Lee on that aspect. I don't think there is any data or anything that suggests that a plant-based diet can lower the white blood cell. And again, I've been at the NIH for 8 years now, and going to 9 years. But yes, even on our clinical trials, we don't make any, diet restrictions, and even for some of our agents that may have a risk to lower the counts, but I don't think we have enough evidence to say that. I agree.
Great, thank you for all three of you. On the testing question, in that area of testing, there's a question that came up about how often an echo should be done in patients. So Dr. Lee, would you like to start with that one?
Okay, so this is also a kind of a controversial topic. Whether or not to do baseline echo as well as serial echoes in patients with neuroendocrine tumors. I think this really applies to potentially patients that have carcinoid syndrome. So those patients that have excess serotonin access, because over time, this potentially can cause an effect on particularly the right-sided heart valves. I think in patients that have carcinoid syndrome, it's reasonable to get an echocardiogram and then followed serially, depending on the overall extent of valvular damage within the heart, as well as symptoms, and as well as kind of control. But there's no kind of set guidelines, even in those patients, in terms of how frequent you need a echocardiogram. So I think again, it's a provider-patient discussion about that. But for patients that have no suspected carcinoid syndrome, I wouldn't necessarily favor a routine echocardiogram, because I don't think you're necessarily going to find much unless you have a specific indication that you're looking for, symptoms like shortness of breath, chest pain, whatnot.
Mm-hmm.
Yeah, I agree. I think, I get a baseline echo on patients who have syndrome, who have at least 3 to 5-fold elevation in their 5-HIA. And the patients that I get nervous about doing serial echoes are the patients where I just really can't get their 5-HIA down. They're on maximal doses of somatostatin analog, they're taking short-acting, and they're on Zermello, and their 5-HIA is through the roof. And that's usually the patients who have high liver burdens, in my experience. And no matter what you do, they're still cranking out that serotonin. And so for them, I might follow their echo once a year. Mm-hmm. I think if you get their 5-HIA down, their serotonin is controlled, and you had an echo that didn't show any valvular damage, and I don't necessarily think you need to keep doing an echo unless they develop a symptom or they complain of something in particular.
Right. And I have to say that I agree with Dr. Kotiah, even though, as Dr. Lee mentioned, there is no guidelines that tell us how often you need to do the echo, or what patient population you need to do the echo. But I do agree with Dr. Kotiah, and I actually follow her same approach, in the sense, if we have a patient that have high hydroxyndolacetic acid, it has, large tumor volume, that you're trying to lower this, the levels, and doesn't come down, I will be more, in those patients, I actually do serial echoes once a year. For the other ones that don't necessarily has the classic carcinoid syndromes, maybe not significant volume of disease, or high hydroxyndolacetic acid is controlled on the somatostatin agonist, I may not necessarily do the echocardiogram as often. But again, this is something that is, every provider may have a different of opinion, and we don't have any guidelines about that. And that will be a great question. I think something that we can definitely bring to the organizations like NETs to say, what do we need to do for this carcinoid heart disease, to say, and that's a great question. And we definitely will bring it to the NETs board of directors about that. I think that makes sense. What do you guys think? Dr. Lee and Dr. Kotiah?
Yeah, I agree.
Well, Dr. Kotiah, you mentioned tumor burden both in your talk and just now. So I guess a question that comes up sometimes in our support groups is, how do you determine tumor burden, and how do you measure the percentage and decide how much tumor burden is too much? And before you answer that, there was actually a question that even asked, how do you determine if liver lesions found during ultrasound are NETs? So if you can answer that first before getting into tumor burden, that'd be great.
What was the, how do you know? You don't, okay, so probably the radiologist will make fun of me, but usually when they scroll through, if I'm like, oh my God, then that's a high liver burden. No, that's not, no, I'm just joking. So I don't think you could tell by ultrasound if you have a if you have metastases from neuroendocrine tumor. Imaging, except if you're doing gallium scan or a copper 64 scan, those scans kind of tell you that there's receptors on there that you can see with slow growing neuroendocrine tumors. Other than that, like a biopsy, and sometimes MRIs, if they're vascular tumors and they light up well, they have that characteristic finding, like the radiologist be like, this looks like a hemangioma, this looks like a cyst, this looks like a neuroendocrine metastasis, right, in the right patient who carries the diagnosis. So, we as oncologists, I'm going to speak for all three of us, we don't want any liver burden, but, obviously, everything kind of hinges on the patients. Like I remember when I started practicing 10 years ago, and I was starting the Neuroendocrine Tumor Center, a couple of patients came to me and said, well, we were told we don't have to worry about it because it's not really a cancer, so we don't need treatment for it. And these are patients who had liver metastases. And I had a guy recently who came from Puerto Rico who was 4 years, they were watching his liver metastases grow, and now he has a very high tumor burden. To me, high tumor burden is any tumor burden over 50%. That's sort of in my mind, it's not scientific, that's just how I think of it. How do I quantify the tumor burden? I just kind of get a sense from the radiologist how much they think. It's like a very crude thing. They don't like it when I pin them down on it. They don't like it when I tell them to give me a percentage, but I sort of like ask them, well, how much of the liver do you think is involved? And then they kind of give me their estimate based on their experience. I don't know what Dr. Lee and Dr. Del Rivero do.
So Dr. Lee and then Dr. Del Rivero.
Oh, sure. I agree with Dr. Kotiah. I think liver burden characterization is somewhat subjective. But if you take a look at, let's say, other diseases that are also involved with vascular tumors. So, for example, I also treat liver cancer. So, liver cancer specifically in the liver and everything. A poor prognostic, factor is greater than or equal to 50% of the liver, and that's been shown over and over. So for those patients where primarily their disease in the liver, that's the threshold that we typically use. I think that's very reasonable to consider that, for neuroendocrine tumor patients as well. I do agree with that as kind of how you make the judgment of significant liver burden.
Yeah, I agree with Dr. Lee and Dr. Kotiah. So first,
thank you. And on that note of the testing again, Dr. Kotiah, here's a question about the scans. You were talking to the radiologist. First, chest, abdomen, and pelvis CT, is there an optimal thickness and increment? And the second question, is it preferred for brain MRI to be on a Tesla 3 versus a Tesla 1 MRI machine?
I will tell you my recent experience. I'll start with the last question first, Lisa. So, I had a patient who was asymptomatic, and she actually had a lobular cancer of her breast, and she had this MRI, Tesla 3, ordered by her radiation oncologist, and they diagnosed her with potential early leptomeningeal spread, which is basically that there's tumor tracking along the brain and the lining. And of course, it created a whole lot of anxiety. And she's 37. She has 3 kids. She's an ER physician. And it turns out that it was just an artifact from the Tesla 3. So, I'm not a radiologist to sort of pick one versus the other. I order a brain MRI with and without contrast when I want to look at somebody's, brain and make sure that they don't have metastasis. And then I let the radiologist work out the kinks. In terms of pan scanning or scanning the body, I don't usually do a CT of the chest unless somebody has no lung nodules there that I'm following. In terms of, in the adjuvant setting, when I'm sort of following somebody who doesn't have cancer, we're just kind of following their disease, I usually do a chest x-ray once a year, and then I really just kind of focus on their liver imaging. But I order CT angiograms, like a triple phase contrast, I think that, the technology is pretty good now. And I think if your CAT scan is not showing you liver burden well, it doesn't matter how fine point the picture is. It's just not going to be a great scan for you. Maybe the MRI is better. But I think if you're, CT with contrast, your CT angiogram or whatever you're getting consistently showing your disease burden, it's going to. So I don't really tell the radiologist what to do, except I do order CT angiogram versus triple phase CT, but how they do their procedure to get the picture, as long as they get a good picture from me. And if they tell me, I didn't get a great picture, you need to get an MRI or you need to get something else, and I follow their instructions on that. That's sort of how I approach things. So I'll let Dr. Del Rivero and Dr. Lee sort of chime in here.
Dr. Del Rivero?
Yeah, yes, I do agree. I'm not a radiologist, and I usually kind of like request scans, and I don't specify to the radiologist like what kind of, how many, if it's thin cut versus, and how much is the thin cut. It seems like whatever scans they are is like either 1 millimeter or 4 millimeters cuts. So I can tell you an experience as well. I mean, I at the NIH, we do have a fantastic surgical team for thoracic LACNETS as well for any abdominal neuroendocrine tumors. And sometimes in preparation for surgery, my thoracic LACNETS may say like, you know what, I may need a different CT scan of the chest with more thinner cuts because I need to know, what's going on and what will be my plan for surgery. I think that now, I mean, in terms of the imaging studies, I think, it has been more modernized. I think we have very good techniques. I think I personally just ordered like a regular MRI of the abdomen pelvis for follow-up with just CT scan of the chest if needed as a follow-up for my patients, but I don't necessarily ask, the cuts. But I have to tell you my experience with my surgeons, they may want a specific CT scans that they wanted to see specific structure in preparation for surgery. And that's when we need to specify about what cuts, what measurement, what they need to do. And I think that's the only way that I can specify about that. Yeah.
Got it. Dr. Lee, do you have anything to add to that?
No, I generally agree. I think it's also the technique. So sometimes, particularly with MRIs, you want to make sure that there's not too much motion when you're taking the MRIs. You take the deep breath at the right time and everything, so that you get a good picture. Sometimes, if the techs at different centers don't tell the patient to follow those, then you're gonna get a bad image no matter what, and you might have to repeat the imaging. So.
That's a really good point. I think those of us who have MRIs remember those instructions to take a breath and to hold it here and there. So another question about testing, Dr. Kotiah, I'm going to give this one to you, is about NET testing. How does that compare to the chromogranin A, and if it's better? And if it is, why is chromogranin A so widely used and NET tests considered controversial?
In the last 10 years that I've been doing the endocrine tumors, there's been many criticisms of the chromogranin A and how it's an imperfect test that can be influenced by many things. And there have been, attempts to try to improve on that. And just generally as an oncologist, tumor markers are things that can guide us, and sometimes it's helpful when they're trending. There's never a perfect tumor marker for every tumor, unfortunately. And so I wish, I draw chromogranin A, but I wish I didn't, because I think people get way too nervous about their chromogranin A, and I'm really looking to treat their scans. I think that, I have not ordered a NET test, and I have sometimes ordered pancreastatin levels because they tend to be less prone to fluctuation of the chromogranin A, but I've never had a tumor marker influence my management. And that's ultimately what it boils down to. Somebody has to show me that a NET test is going to impact the survival of my patient, and that somehow by intervening early, because I'm seeing a trend in a blood test, that it's going to help the patient have a better outcome. And right now, there's still too many unanswered questions. And I'm more than happy to acquire the test. I've acquired many tests to try to make sure that I have a better understanding. But for neuroendocrine patients, the most important test for me remains the 5-HIAA when I'm trying to figure out about quality of life and symptom control. That's what matters to me the most. And I can draw these NET tests and chromogranins and pancreastatins and watch the data trends, but ultimately it creates a lot of anxiety without helping the patient's overall treatment plan. Because I'll treat the scans, I'll treat the burden in the scans, I'll make sure if the cancer is growing, that's what triggers me to change my management. If the patient's symptoms are not controlled, that's what triggers me to change my management. But I'll defer to my colleagues and see what they have to say.
Dr. Lee, I know that you're going to be ordering NET tests with your open clinical trial.
Yeah, so I think we have to really, I do agree with everything that Dr. Kotiah has mentioned, in the sense that we never make a decision based off of a blood test in isolation. So what I always tell my patients is, we make a decision in terms of treatment management. One, clearly in terms of how the patient is feeling. That's always number one. Number two is the imaging, and then three with the tumor marker. All three together in context, and make a decision of whether or not the tumors are growing or not. So I also do agree that without prospective, well done trial showing a potential survival benefit with a biomarker, that you're not necessarily going to really change how you're going to practice. So I think as a society, as well as a neuroendocrine tumor community, we have to really understand, if we're going to do some of these studies, is it worth it? And is it really going to change management and improve outcomes? And we have to question that, because our resources are somewhat limited. So we don't have the luxury of infinite resources and everything. So we have to really pick the highest priorities in terms of how it can really impact and improve the lives of neuroendocrine tumor patients. So in our trial that we're doing with Dr. Chauhan's trial with PRT with TrialPen, there is the NET test that's built in as a correlate of science. So it's really just to see whether or not we can use the NET test and generate some prospective data that will be openly discussed and everything, to see whether or not that there is some type of signal that you see in relation to, let's say, response or following of the patient over time. That trial is relatively small, so it's very exploratory in nature, and you don't spend too much resources on it. So I think it's worth investigating. And if you do see something in terms of a signal, then it's worth further investigation. But throughout the time point, we always have to raise the question of whether or not this is worthwhile doing in the long term, in terms of like what Dr. Kotiah has mentioned. Is it going to change our outcomes? Because if the answer is no, then I would say we should not be doing it.
I'd like to move on, since you brought up PRT. There's a couple questions about PRT, and Dr. Lee, if you want to take this one first, what are the types of scan and the timing of each to best track the effectiveness of PRT as you progress through the treatment and post-treatment?
Yeah, so I think this has changed within the field as well. For me, luckily, it hasn't changed. So I stood my ground on this and everything. So usually what we do, and certainly this is not, I think every single provider is going to be different, but originally it was thought basically you just get a scan in terms of anatomic imaging, so CT or MRI, as well as a baseline gallium scan prior to treatment, just to make sure that all the disease has somatostatin receptor positive tumors, and then you treat, and then you don't image until end of treatment. And I saw that from all the experts, saying that and everything. Again, I'm an oncologist. My approach has maybe differed slightly as a result of that. So what we did was we would always scan in the middle, just because what we wanted to do was to get a thought in terms of what is going on with the patient. We understand that there could be mild progression, and in our hands, we know that, and we expect that occurs sometimes with treatment, and that wouldn't necessarily impact our treatment, but it does allow us to just make sure that there's not a patient that's rapidly progressing. And that's always kind of been our stance, and that's always what we've done. So we essentially get baseline scan, and then scan in the middle, and then scan at the end of treatment, and then traditional surveillance imaging after that. Other people will disagree with that and everything. But again, even with the disagreement, there is no prospective study that shows that, let's say, early imaging or late imaging leads to better outcomes either way. So I think, again, really have that discussion with their provider. What is the rationale behind their approach? And if it makes sense to you, then I think you guys can, really come up with an agreement.
And Dr. Lee, when you say the scans you're doing in the middle and afterwards, which type of scans are you doing?
Still anatomic imaging. At the end of the day, gallium is not meant to follow in terms of changes in size of the tumors. It's meant to have an assessment of whether or not the disease shows somatostatin receptor activity and where there is, disease in terms of its, very, high sensitivity. But it's not necessarily meant to evaluate for change in size of the tumor. So you still need anatomic imaging as your fundamental baseline.
Okay, so you're ordering a CT or MRI. And Dr. Kotiah, how about you? How does your practice difference in terms of what types of scans and the timing of the scans that you order to track the effectiveness of PRRT as you progress through the treatment and post-treatment?
Yeah, I mean, I pretty much agree with Dr. Lee because, we get a baseline gallium scan just to make sure the patients are eligible for PRRT. And then we usually have a CT or an MRI, whatever shows the liver burden better, going into the PRRT. There are, I know in practice, we're supposed to be treating well-differentiated G1, G2 patients, but there are well-differentiated G3 patients who have positive gallium scans. And for them, if I'm putting them through PRRT, I am more worried about progression in them and making sure that they're not progressing rapidly on the treatment. So it's hard to go 8 months without knowing what's going on because you don't want to be caught unaware. Actually, not even 8 months, 11 months, right? So if you go through the whole course of PRRT and then you wait like 2 or 3 months to re-image, which is what people had been recommending, what other neuroendocrine experts have been recommending, then it will take you almost a year to find out whether PRRT has been effective. And I think that for your patients who definitely have slow biology and you've been following them for a while, that makes absolute sense because it can take the third or the fourth treatment for things to actually work. And the only time I do a gallium scan after PRRT is in somebody who had extrahepatic disease. And they had like bone lesions or lung lesions, and I want to make sure that they've responded uniformly, although honestly, it's the liver burden that drives the survival. And it's important to see whether things are growing or shrinking in the liver. But, if somebody had really bad bone involvement and I want to make sure that it's deactivated, then sometimes I'll do a gallium scan, but usually we follow the lesion size, and I agree with him about that. So I don't know if that helps or not, but that's sort of my thoughts on it.
Dr. Del Rivero, what's your practice?
Yes, I think that I completely agree with Dr. Lee and Dr. Kotiah. One thing that I want to mention is so what do we do in the setting of overall clinical practice, and what do we do in the setting of a research or in the setting of a clinical trial? And I think that's a little bit different as well. I think in terms of the clinical practice, I think that's the standard. And I think that's what Dr. Lee and Dr. Kotiah has said. You always get your baseline gallium scan. And then after that, you may or may not do, I think everybody kind of do another scan at the end of the 4 cycles of PRRT. And they follow, with either MRIs or CT scans, whatever preference is the provider is choosing. In the setting of a clinical trials, we may do a little bit more often just because that's what we wanted. We have specific questions that we want to answer. And I can tell you, at least for our FIO-PARA trial with PRRT, we do have 1 or 2 scans or gallium scans that we have done because we have seen that this patient may have progressed even after 1 or 2 cycles of PRRT. And as Dr. Kotiah says, maybe we wanted to really determine, of course, correlating that with anatomical images so this disease is progressing. But that's another thing that we have seen that maybe with the more rapidly growing, maybe you don't want to wait until the end of the treatment. Maybe you want to do it sooner. But again, so kind of the question is what is allowed within the clinical practice and the things that we do within the research setting. But in the research setting, we do it more often just because, at least 1 scan in between because we wanted to know what is efficacy. We wanted to know if it's worth to continue. And at least on our FIO-PARA patients, some of them, we have discontinued treatment and they have not been able to complete the 4 treatments of PRRT because of that.
Great. On a related question, and we'll start with you, Dr. Lee. As you progress through the rounds of PRRT treatments, what are some of the indicators of treatments having a positive impact?
Yeah, so we can certainly see, a potential positive impact, again, through various different things. So 1, are you clinically feeling better? Usually, if you're clinically feeling better, that's the absolute first sign that you're potentially responding to treatment. Second, you can potentially look at blood work. So sometimes if someone has, let's say, a lot of liver burden, they might have elevations in terms of some of their liver function tests. And over time, that liver function test might come down. And that might be indicative of a good response, for that patient. And then lastly, ultimately, with scans, you'll be able to see whether or not there's been a change. So again, just like everything else that we do, it's just not just one component, but there's all these really kind of three major components that we look at to assess for response.
Okay. But syndrome, I had a patient who had one dose of PRRT, he had a VIPoma, his diarrhea, he didn't have syndrome, he had a VIPoma, his diarrhea went away, like it was amazing. But sometimes if your syndrome is getting better and your 5-HIA is dropping, then there's hope there that the PRRT is actually doing you some good too, apart from what Dr. Lee said. I would add that.
Yeah, I agree.
Okay. And what about those who don't have any syndrome, that are non-functional?
Yeah, then it's hard to tell without imaging, I think. Yeah.
Yeah, but you could still have symptoms as a result of tumor bulk, right? And if your tumor bulk is improving and everything, then you could still see, or feel a potential response.
Right.
Great, thanks. Speaking of feeling badly, let's go back again to symptoms. And Dr. Del Rivero, NET patients have an excess of serotonin, as you know. So does this cause mood swings, irritability, fatigue, and depression, or does it only cause physical symptoms?
So this is what I have seen, and I also would like to know Dr. Lee's and Dr. Kotiah thoughts about that. But, what are the symptoms related to excess serotonin? And that's kind of like one of the things that I have seen besides the diarrhea, besides the flushing, because that's kind of like quite significant, especially when the serotonin, because one thing, we talk about the urine test with the 5-hydroxynilacetic acid, but what is that? Is the breakdown of serotonin. So, and sometimes, what the symptoms with this excess of hormones, they can cause, as I say, diarrhea, they can cause flushing, it can cause fatigue as well. One thing that I have seen is that they can also cause vitamin B3 deficiency. And because of this vitamin B3 deficiency, that can also be associated with the symptoms associated with vitamin 3 deficiency, which is the depression, which is the skin changes, which is, so those are the things I have seen, but those are the patients that has a significant high levels of serotonin. I think that the excess serotonin can definitely cause symptoms. And that's the reason why, whenever we have this excess serotonin, it's like, do we need to treat? And as well, whenever I see a patient in my clinic and I see them, it's like, and I measure the hormones and I see how high they are, I always ask 2 questions. And that's kind of like, I always teach my fellows those 2 questions. It's like, what am I going to do for the symptoms? How can I improve his symptoms, the current symptoms because of the hormone excess? And then what do I need to do in order to control the tumor growth? So those are the 2 things. Sometimes, like I know that we treat one of the other, but regarding to neuroendocrine tumors, that besides the serotonin, the pancreatic neuroendocrine tumors can produce excess of insulin and somatostatin, which is rare, BIP, which is also rare. But, this gastrin is another one. We see a large number of MEN1 patients that produce gastrin tumors as well. So that's one of the things that I always kind of like teach my fellows is like, what do we do for the symptoms and what do we do to control the tumor's burden as well? So even though they're related, but I wanted to understand that there are things that we need to do in order to improve the symptoms of those patients.
Right. Dr. Kotiah, what do you think about if excess serotonin causes mood swings, irritability, fatigue, or depression?
I think it's more the lack of niacin. There's pellagra, there's depression, there's the shunting of the pathway to make excess serotonin creates like a niacin deficiency. And there's definitely mechanisms that can explain depression, like Dr. Del Rivero was saying. So I think it is a very real thing that patients who have syndrome have more mood swings and depression and mental health issues. And, just also from the standpoint of having cancer itself can give you mood swings and depression. So, mental health is extremely important because it helps. If it's aligned, it helps us with the physical health. So, it's nothing to be dismissed. Patients have to be treated globally because if we're, not treating their depression, we're not treating their mental health, we're never going to be able to get their disease under control the way we want. I mean, that's sort of how I feel about it. It's very tightly linked.
And Dr. Kotiah, I think you say a very important word, like mental health is important, and we have to treat the patient globally. It's so important, and I'm so glad that you say that, because it is very important. And one of the things is because even having this diagnosis, the fact that you have the cancer diagnosis is just generate a lot of stress and anxiety on the patient well-being. Despite of the symptoms related to the hormone excess, the fact that having this diagnosis and living with this on a daily basis is just generate a whole turmoil of feelings that is important that we treat the patient as a whole. And another thing, just to put my endocrine, here, is that even though there's a lot of these treatments, or even, the fact that having cancer itself can also downregulate the endocrine system. And a lot of this, we can also see that they lower the estrogen levels, even in a young patients, or testosterone levels as well. And those lowering of hormones, other endocrine hormones, that can also translate on patients not feeling well, feeling depressed, feeling not itself. But I do agree that, treating the patient's mental health, treating the patients globally as a whole is super important. Thank you for saying that.
Thank you too, Dr. Rivero, for saying that. And another endocrine-related question is, Dr. Rivero, what are some different causes of hypoglycemia or reactive hypoglycemia among NET patients?
Oh, wow, that's good. Yes, that's a good question. So in terms of reactive hypoglycemia, so hypoglycemia related to insulinoma, hypoglycemia related to reactive hypoglycememia. So as we know, there are other things that can cause hypoglycemia. Drugs can cause hypoglycemia. Somebody's on insulin, somebody's on oral diabetic medications can cause hypoglycemia. Anybody who doesn't have enough liver reserve, that can also cause hypoglycemia. Somebody who doesn't have good kidney function can also cause hypoglycemia. Those are other causes that can cause hypoglycemia. But now in terms of the neuroendocrine tumors, we know that insulinoma can cause hypoglycemia because the excess of insulin can lower the glucose. But at the same time, reactive hypoglycemia, we see a lot of the patients that have surgical abdominal surgery, like Whipple disease, that they have this reactive hypoglycemia because of the surgical intervention. Sometimes it's quite difficult to differentiate one to the other. And that's a great question, because the two of them has high level of insulin, high level of C-peptide, low levels of glucose, the two of them. So it's sometimes very difficult to differentiate insulinoma related to neuroendocrine tumors or reactive hypoglycemia. And the best way to differentiate the two of them is by doing what we call a dynamic test, by you doing a fasting test in the hospital setting, or by doing also a mixed meal test with a hard carbohydrate test. And the reason why is because reactive hypoglycemia it usually happens after eating a high carbohydrate meal, and it can happen anywhere from 1 to 4 hours after they ingest the carbohydrate meal. So that's another way to differentiate between the two of them. Insulinoma can happen anytime, regardless of what you eat, but the reactive hypoglycemia usually follows a high carbohydrate meal. But in terms of the labs, it's very difficult to differentiate. So that's why when that happens, we then need to do more of an testing to differentiate it between the two of them.
Great. Thank you.
That was all her.
Great.
Great explanation. Thank you.
Yeah, that was great. Dr. Del Rivero, actually, since we have you here, here's another related, or in that field, in your field, are parathyroid or thyroid tumors or hormonal issues related to NETs? That comes up often.
Okay, so MEN1, multiple endocrine neoplasia type 1, has been associated with we call it the classic 3 Ps, but we now know that it can have other clinical manifestations related to MEN1. But in terms of multiple endocrine neoplasia, they can have neuroendocrine tumors, and that can be anywhere in the body. It could be lung, it could be thymic, it could be pancreas, small bowel neuroendocrine tumors. But they also have, in most of these patients, they have primary hyperparathyroidism, meaning that they can have a parathyroid adenoma that is causing excess of parathyroid hormone. And what the parathyroid hormone is doing is basically upregulating your calcium levels. So parathyroid hormone raises your calcium levels. So that's one thing that we have seen in relationship with multiple endocrine neoplasia. We also have seen other patients that have multiple endocrine neoplasia. They may have thyroid and as well as pancreatic neuroendocrine tumors, but it's not often seen. I will have to say in terms of the parathyroid, yes, we have seen the parathyroid adenoma with the pancreatic neuroendocrine tumors. And it's usually what we say a patient that we label an MEN1 patient, just because we know that the MEN1 gene testing is not positive in everyone. But if you have the clinical manifestation of having 2 of the 3 MEN1 clinical manifestations, we label them as an MEN1. In terms of thyroid disease or thyroid cancers, I mean, associated with neuroendocrine tumors, not as often as with the MEN1. But one thing in terms of like in my experience with, I don't know, Dr. Lee and Dr. Kotiah, sometimes I see with the long-term use of somatostatin agonists that they can also cause hypothyroidism. Even sunitinib, certain drugs can also lower your thyroid hormones. And that's something that you need to check regularly as well. And those patients using these drugs, I want you to check the thyroid hormones, because and that's another thing is they feel very fatigued, they gain weight. So that's another thing that you need to make sure that you also check the thyroid hormones, because sometimes they can affect the thyroid itself, those medications.
Great. Dr. Kotiah or Dr. Lee, do you have anything else to add with that? Okay. Let's go to a pretty straightforward one. If your 5-HIAA, I'll give it to you, Dr. Kotiah. If your 5-HIAA and chromogranin A are normal, but you have liver lesions, does this mean they are non-functioning?
Usually, yes. I mean, if you're not having any symptoms, that doesn't mean the chromogranin, again, the chromogranin A is an imperfect marker, right? So there are people who have normal chromogranin A, but they have actually like a high, like they have metastatic disease in their liver. So you have to follow what you have, like, so if the blood work is not going to help you, then you have to follow the imaging. So yes, but usually I would say that they're non-functional.
Okay, Dr. Lee?
Yeah, I agree.
Yeah, the same.
Great. And in this area of clinical trials, okay, so let's go with you, Dr. Lee. Can a person with no remaining options enter a clinical trial on a compassionate basis if they don't explicitly qualify based on the number or type of past failed treatments?
Yeah, that's a very good question. So, I mean, this kind of goes to the point that I was trying to highlight earlier in our discussion in terms of, clinical trials come and go. Clinical trials also depend on whether or not you're eligible for a clinical trial based off of meeting certain criteria within the trial. So, as a general aspect, you usually wouldn't necessarily want to go on a clinical trial if you're really, really sick, because that can, and the reason why is, one, are you going to be able to tolerate the experimental treatment? So that's a safety issue for you. But two, it also has an impact on the greater NET community as well, because if something does happen, well, was it a result of your underlying condition that you were in, just because you were relatively having significant disease burden and more impacted as a result of the condition that you were in entering the clinical trial rather than the actual treatment. So it has a huge impact. So that's why, you want to have that discussion with your provider in terms of creating the optimal timing to go on a clinical trial, and usually never too late. For a patient that is in that scenario where they have exhausted, let's say, all FDA approved treatments, and they're still looking for a clinical trial in a refractory setting, and they don't meet the criteria for a clinical trial, whether it's due to laboratory reasons or other reasons, then you can potentially try to get the medication, if it's already FDA approved for a different type of indication, on what's known as a compassionate use program. So this is very complex, but essentially you have to submit to insurance. Insurance either accepts it or denies it. If insurance denies it, if there's a patient assistance program within the company that makes the drug, then you submit it to that and you essentially get approval or not for the medication, and then you can use it on a compassionate care program. If the drug is actually not FDA approved, then you can potentially do what's known as a single patient exception clinical trial. So a clinical trial just for that one specific patient. I will say that's very, very, very rarely done, because the issue is that there's a reason why you're not eligible for that trial. So why would you potentially write a single patient exception to treat that patient on a drug that is not yet FDA approved for anything else, whatnot? So that would be a very, very exceptional case where you would do that. And it's in my whole time, practicing, I've only done that for one patient, and there was a specific reason why we did it and everything. And there's usually usually we would not go down that pathway if a patient's, because there's a reason why you didn't qualify for the trial, and it's a potential safety concern that we're concerned about, because we have to put your safety at the first part of our decision when we're making these decisions.
Mm-hmm. I did do it recently. But it was for a patient who the trial closed.
So that's one of those scenarios, right? Because you would otherwise qualify.
But you had to give away your firstborn child. I mean, the IRB. I mean, there's so many rules. The patient has to come in every month for blood work, and you really have to kind of follow what the trial was going to do. So they really make you jump through hoops, but sometimes it's worth doing if you feel like the patient is going to benefit from it. But I agree. I mean, you summarized that very well, Dr. Lee, I have to say.
Yeah, I agree. Lisa, do you mind if I ask a question to my colleagues?
Sure.
Is that okay? So I was just wondering, what are you, like, for example, for FIOPARA, that's a neuroendocrine tumor that we treat at the NIH, we have as an eligibility exclusion criteria, like not previous, that they haven't received MIBG. So if a patient receives MIBG, that's an exclusion criteria. But we feel that the patient may benefit from Lutathera. They cannot enroll in our studies. But I don't know if there is a compassionate program for Lutathera. So we're just wondering what would you recommend in those situations? What would what would be the steps in order to get this patient Lutathera?
I don't think there's an issue, in terms of getting Lutathera, and I think it also depends on what the insurance is, because there will be differences. So here in California, especially with, let's say, Kaiser. So Kaiser is a large organization, managed care insurance, as well as essentially providing care to patients. What's interesting about Kaiser is that I've actually really welcomed Kaiser. So while Kaiser won't necessarily allow, let's say, a patient to come to us to get standard of care, if we're able to provide something that Kaiser is not able to provide, let's say, such as Lutathera, for example, Kaiser actually has been very good about that. So they don't have to follow kind of the traditional, let's say, FDA approved like indication for Lutathera that we have right now. Because their own insurance, they're basically saying, like, we're sending this patient for you for your advice on Lutathera. If you as a practitioner feel that the patient can potentially benefit from Lutathera, and we have the data for that, even though it's smaller data and everything, we do have the data for that, then they're going to say that's okay. And so you don't meet that same challenges as, let's say, larger, private insurance and whatnot. So I think it's insurance dependent and everything. But even if they can't, then, it's always a discussion with the company if the insurance denies whether or not they have an assistance program that will help.
Okay, that's great.
Definitely going to move to California. We're like the only capitated state, like Maryland. So reimbursement is a huge issue for us because, all the hospitals are on a budget that was set. Medicare sets the rules, and Medicare denies anything that's not FDA approved. So it's a struggle and a challenge in Maryland to treat anybody off trial with a treatment that you think might benefit them. That involves, expensive, especially if it's expensive. Like, I've had to use mainly, like for immunotherapy, I've had to appeal to the companies that make the drugs to give us compassionate use of the drugs. But for something like PRRT, where they don't really have compassionate use anymore, and it's going to cost a whole lot of money to give that treatment, there's going to be likely a very much a denial from the insurances just because the private insurers are following Medicare. So, so that's been very tough for us. And so we're very challenged by that. And apparently all the other states are going to be capitated over time. I've been waiting 5 years for Florida to be the next state to be capitated. So we were supposed to be the model which controlled medical care costs across the US, but it's been very challenging for us. We're doing our best, but our patients are still, I think, getting very good treatment.
Yeah, no, I mean, it's the one scenario where I think, for us with Kaiser being, HMO and everything, where that creates a more opportunity compared to private insurers and everything. So I think it's very different, state to state, as you mentioned. And, and even within the state, that there's differences. As Lisa knows, like Kaiser could potentially internally refer their patients for Lutathera. There's been certain Kaiser sites that have developed Lutathera, but then at least so far, I think there have been Kaiser providers who recommend, who have acknowledged and understand the potential advantage of referring these patients to see a NET expert for their Lutathera, even though they have certain specialized centers that do that.
So actually that leads me to the next question. Someone asked, is it important to have a NET specialist? And perhaps that's more of a question for me than it is for you guys. But I hope that whoever asked this can see the difference, right? Between these 3 NET experts answering these questions versus perhaps a local or community oncologist, and perhaps what you have to offer, like what you were saying just now, Dr. Lee, about that. And do any of you have anything to add about, I guess, more, not so much is it important to have a specialist, but what might the difference be? Dr. Lee?
So, it's a hard question for me to answer because I always know kind of where I came from and everything. And so I always want to be, cognizant of that. I think, you need to find a good doctor. At the end of the day, you need to find a good doctor first. So someone who's, willing to, follow your case, offer you very open discussions and, good advice, regarding your case, and be willing to, really take care of you in terms of how you want to be taken care of and everything. And that might be good or bad in terms of, discussions of, frankness of the discussions and whatnot and everything. But I think, first of all, you need to have a good doctor who's kind of in your corner. I've seen a lot of, community oncologists who might not be viewed as NET experts, but they were great doctors. And they've been able to manage their neuroendocrine patients really, really well and everything. And they've been able to do exceptionally well. So finding a good doctor in your community, I think, is really important. And then, kind of seeking out the advice of quote unquote NET experts. And I think in this area, NET experts vary a lot and everything. And I might be, not giving a truly popular opinion in these days, but I think it's an opinion that we have to start talking about in the NET community. You have certain types of NET experts who are, let's say, just focused on research, but doesn't necessarily see a lot of patients. And that's okay, because they're going to help you design and identify the next generation of compounds that are going to be very important in care and everything. But then your expectation from them is that they might not be able to handle kind of the day-to-day things that you're looking for, versus someone who's, let's say, a NET expert who sees a ton of patients every single day. And I know all of us here are seeing a lot of patients and everything today. So we know how to handle potentially the day-to-day, kind of complications as a result of that, and may be able to manage the patient, much better and everything. And then you also have to have that expectation of, are you going to go to the NET expert as more of a kind of a consultant, let's say every 6 months or a year and everything, and kind of travel throughout the United States, to do that? Or are you going to actually be treated there? Because that's going to be different in terms of the expectations that you're going to need. Because if you're seeing someone, let's say, once a year, that person necessarily is not going to be able to manage your day-to-day, symptoms or day-to-day, adjustments in medications and whatnot. And you're really going there for a change in a time where there's a potential change in your management or treatment. So I think those are all kind of things to keep in mind. But at the heart of it, you really need a good doctor, because no matter for all of us doctors, we were not a NET expert from day one. And we have to remember that. And that has come over time in terms of the number of patients that we have seen over time. And you should not necessarily use kind of age or anything else as a measure of experience, because what you've seen with what Dr. Del Rivero as well as Dr. Kotiah have shown is that the treatments that we're using for neuroendocrine tumor patients are vastly changing, and they're changing very quick. So it's really how much experience they have with that treatment on a day-to-day basis that's going to be very important for you.
That's a really excellent answer.
I was going to say, I'm a community oncologist. So,
I know, and you're a great NET expert.
You see a lot of patients.
Yeah, so I have to say, I have my own viewpoint on things. I never really expected to develop a neuroendocrine program. I came out of fellowship just trying to build a practice in the hospital. And the head of our cancer institute said to me, there's so many neuroendocrine patients out there. We're operating on them. He's a surgeon. More and more, we really need to create a center like we did for our appendix cancer patients. And it sort of built, from like 30 patients to like over 800 now in the last 10 years. And I'm sitting between like two academic institutions. And I've seen patients being referred to me from those, patients who are coming to me from those institutions. And I don't manage them the same as the oncologist there, because I feel, like I've seen a lot and I've seen all the good and bad. So I have my own approach. Not always, but sometimes I don't approach it quite the same. So, I, in the converse, when I see a patient come to my office with a cancer that I don't treat a lot of, like sarcoma or like glioblastoma, I will tell the patient, listen, I don't treat a lot of this type of cancer. You need to go to somebody who treats a lot of those cancers. So that, because I know my limitations. If you see that type of patient every, once a year or like twice a year, the type of patient, that you're not really doing them a favor by keeping them in your practice, because then you're sort of, kind of like, well, I don't know how you're going to react to the treatments because I haven't given this treatment a lot, but I'm hoping that I know how to manage it. Like that's sort of like how I feel about it. So I will, and if the patient's like, no, I really got to stay with you because this is more convenient for me, I live down the road from you, then I will liaise with that expert wherever they are. And so I try to offer the same service. Like, if you want to come see me for your neuroendocrine tumor, but you live 4 hours away, 5 hours away, which happens a lot, I'm happy to manage you, see you once a year, twice a year, and help co-manage with your local oncologist. Because it's not about, it's more of a collaborative thing. And, it's not so much like for me, and I think for us, it's more just about overall improving the treatment of neuroendocrine patients across the country. And if somebody is not familiar, not comfortable, I'm more than happy to help, lend my thoughts. And like Dr. Lee said, we don't all the neuroendocrine experts don't always manage everything the same way. And that's okay, because there's an art to this. And it's basically your experience that guides you just to do one thing more than the other. It's sometimes based on what kind of toxicity you had from a treatment or what kind of success you had with a different treatment. You want to start with something first versus something else first versus another neuroendocrine expert down the street. So it's always good. I think one of the great things that I enjoy about the neuroendocrine tumor groups that we have is that there's a lot of multi-D care, like the multidisciplinary care, and getting other people's input. And I always, run things by my other colleagues across the country, because sometimes you'll see it. For all these years that I've been taking care of neuroendocrine patients, there will be a case that walks in and I'm like, wait a minute, I have not seen this before. So every time I think I have things fairly down, somebody comes in and surprises me. So, and then I have to be like, let me ask everybody else, have you seen this? And sometimes that's a case that we all learn from. And that's the thing that I find amazing about, oncology and even neuroendocrine. You're never too old to learn, and you should always be learning.
Right.
And anyway, I got sort of sidetracked, sorry.
No, that's wonderful. That's wonderful. I think you guys cover everything. And at least in my experience is that, again, we are a research institution and I'm always available. We have patients that come from all over all over the States, even all over the world. I have patients that have come from South Africa, UK, all over the other side of the world. But yes, I do have a commitment with the NET community that I'm available as Dr. Kotiah and Dr. Lee, and provide and help other providers to help continue the care. And I completely agree with you both.
Okay. Well, I know that I've already taken an hour and a half of your time, so let's see if we can get through a couple of these really quickly. Dr. Del Rivero, if grading is intermediate or unclear, are there studies addressing unclear or intermediate grade, or are all studies either very clear, low grade versus very high grade?
Okay, that's a very good question. And I have to say that I will also love their opinions of Dr. Lee and Dr. Kotiah. So the way that we now grade in neuroendocrine tumors is kind of like based on the Ki-67, which we call that's the proliferation index. If it's less than 3, well differentiated, 3 to 20, that's intermediate grade, and greater than 20, that will be grade 3 until, usually 50, greater than 15, then we go into other poorly differentiated neuroendocrine carcinoma. But one thing is that is usually we see that for the gastroenteropancreatic neuroendocrine tumors. My experience, and I would love to know Dr. Lee's and Dr. Kotiah's stories about the lung neuroendocrine tumors, it seems that they have a different classification system to determine typical versus atypical. But how about other tumor types? How about other neuroendocrine tumors like the bladder? We have a good number of bladder neuroendocrine tumors or ovarian neuroendocrine tumors. Can we extrapolate the same classification that we have used based on the recent WHO classification for the gastroenteropancreatic neuroendocrine tumors? So that's the thing that we're trying to understand, but at least for the GI and for the pancreas, we know that this Ki-67 and this gradient really kind of help us to also understand about the biology of the tumors, and as well as it's a prognostic tool. But we still, for the other sides of neuroendocrine tumors, I still feel like there is still more things that needs to be done. And I don't know what Dr. Lee and Dr. Kotiah think about that.
I mean, I absolutely agree. I think that, we still have work to do even with the GI, because, I do think that patients who have Ki-67 of 20 to 55% are different than the patients who have Ki-67 above 55%. And yet we have not done, most of our trials have been less than 20%, or just like, patients who have very high Ki, 80, 90%, and even those patients don't get a lot of trials. Number one. Number two, I've had breast neuroendocrine patients who have Ki-67s of over 90%.
Right.
And then their estrogen receptors are quite positive. And I'm thinking, they need chemotherapy because their Ki-67 is very, very high. And some of them have refused and have done absolutely fine on hormonal blocking. And they're like 5 years out, without recurrence with chemotherapy. So definitely for a rare disease at rare sites, and the challenge is going to be getting enough cases together to kind of analyze and sort of realize what is the right thing to do for those patients. And you definitely don't want to be the patient with the rare disease at the rare site, because sometimes what happens is people correlate with the most common form of that disease and try to guide you in that direction. But we don't really know how to treat those patients. And that's challenging. Right. I don't know how Dr. Lee feels about that.
I agree. I think even for, one disease type, like, just look at kind of the clinical trial data and everything. Even for, GI neuroendocrine tumors, some of the trials will limit Ki-67 to less than 10% and everything. Well, so that puts you in a conundrum, because you could have a grade 2 that's, 8 or 9% versus a grade 2 that's 15 to 18%. And I think what we know is that those patients probably will respond a little bit differently to different types of treatments and everything. And, we have to make a conscious effort in terms of how we're lumping everything together to make assumptions of outcomes.
Okay, thanks for that. And Dr. Lee, you talked about patient preferences earlier. There's a question that came in. Can a patient decide the extent of a surgery to remove a midgut NET? What if a patient wants to keep the valve? So I'm assuming the ileocecal valve, no matter what, if this means not to remove the whole NET.
Yeah, so I think that's, again, a discussion with your surgeon and everything. I think most of us providers really want to work with you guys as patients and everything. But at the same time, I will push back a little bit here on certain things, like, procedural things, especially, big surgeries and everything. You have to have a lot of faith in your surgeon because that's a big decision and everything. And there's a reason why they might be doing certain things, for that. So really have that open conversation with your surgeon, but also be open that you might not, get what you think is the best surgery and everything. And there's a rationale behind that from the physician that's treating you. So in order to have best care, I really believe in kind of this openness and trust that has to be developed. And that's not just, doing everything that a patient wants to do. It's not doing everything that a doctor wants to do. It's really like kind of coming in the middle and saying, this is the reason why I want to do this and everything. And these are why I want to do this. Are you okay with this? And kind of coming into that agreement.
Mm-hmm. Dr. Kotiah, do you have anything else to add? Or Dr. Del Rivero?
No.
I think that's great.
That was well said.
Cover everything, yeah.
Okay. Dr. Kotiah, should someone with a tumor removed from the appendix, so it's already removed, should they get a gallium-68 scan?
I mean, that's a multi-layered question. I guess it depends on the size of the neuroendocrine tumor and whether or not there's features in the pathology report that are concerning that there might be lymph node involvement. I know that we love our gallium scans. I'm guilty of that too. But, I usually don't, do a gallium scan as somebody who had a very early stage appendiceal neuroendocrine tumor where we think the cure rate is high. So, I mean, if it's over 2 centimeters, I probably will do a scan to make sure everything's okay. If there's only the appendix that was removed. Other than that, I don't usually order a gallium scan just routinely.
Okay. Dr. Del Rivero, do you have anything to add?
Yes, I think, I mean, I have to say, I get this question a lot because we have the pediatrics and adults neuroendocrine tumors, and appendiceal neuroendocrine tumors seems to be, we see it more in pediatric actually, and because appendicitis, and then incidentally there was found neuroendocrine tumors. And one of the questions that I always ask is about the extension of the surgery, as well as what imaging studies needs to do in order to determine the extension of the surgery. And I'm actually working with my surgeries to develop like a kind of like a little bit of consensus statement about that, because my surgeons feel like, well, if it's greater than 2 centimeters in size, if it has any invasion to the mucosa of the appendix, if there is lymph nodes, so that indicates, maybe having a baseline scan to determine also the extension of the surgery, and then we can do more extensive surgery. Younger people may respond better to more aggressive surgery than older people as well. But I do agree with Dr. Kotiah, unless it's like greater than 2 centimeters, it has any suspicious findings, I may not necessarily do a gallium scan, but it's true. I'm kind of like also guilty saying like, yes, let's do a gallium scan, and we do it. But again, this is kind of like an area that needs to be further explored, and also have a consensus or guidelines to determine what to do, whether we need more extensive surgery, what is the criteria for more extensive surgery, do a gallium scan baseline prior to more extensive surgery is needed, do a gallium scan is needed after a baseline, and how long. So those are the questions that we definitely need to ask, and it's still an area that is ongoing in terms of research and answering those questions. I don't know what Dr. Lee thinks.
And the other thing is that I forgot to mention is, like having a negative gallium scan is great, but it doesn't necessarily mean that you don't have a neuroendocrine tumor, like microscopic disease hiding. Every imaging that we have is limited by size. If something's small enough, nothing's going to pick it up very well. And there are patients with appendix neuroendocrine tumors where what's going to happen to them in the future is they're going to have disease in their lining of the abdomen, like the peritoneum, because of the way that the tumor is extending outward versus lymph node metastases. So, and peritoneal metastases are very hard to find sometimes on scans, CAT scans, gallium scans, or even MRIs. Like nothing really picks them up that well. So, it's fine to have a negative scan. You're sort of happy about having a negative scan. But getting a scan should not make you feel like, okay, I don't need to do follow-up. You need to do follow-up no matter what. You need to be aware. Right. If somebody says to you, your tumor is very, very small and we've cut it out and the likelihood is low, so, go live your life, do your thing. Usually we have protocols in place. Like, if we're worried about you and we think that you need to be watched, then we will put you on an imaging scan. And, kind of surveillance or, and blood work scan surveillance, whatever. I mean, that needs to be better defined too with NANETS, but we're sort of, I think we're working on being more consistent with NCCN and NANETS, but I think that, I think people can sometimes use it as a crutch. Like, I feel better, my gallium's negative, but like, you just have to sometimes wait things out and hope that for the best,
Right.
Good point. Okay. Well, speaking of tumors in less common sites, Dr. Lee, how often do you see kidney primary NETs? And some doctors might say like it's an unknown primary because they think that primary site is so unlikely, it doesn't matter for treatment.
Yeah, so it is. They do exist for a fact. There's only been a few publications on this. We actually have a publication that we've sent it to the journal looking at our experience in California. So it's definitely real, and kidney primaries are real. So you do have to, depending on the case, make sure that it's not some other primary as well in terms of metastasizing to the kidney. But just as a matter of fact, it is real, and then you have to, manage it because there's not a lot of, guidelines, like kind of like the earlier question. You might try to extrapolate from other, management sequencing or management or treatment that you would do for other types of neuroendocrine tumors, but that there's really not a lot of experience behind this. So hopefully, as we get more experience with this, as a group, we can kind of come together and share some thoughts on that based off of our individual experiences. So I'm actively treating, patients with kidney, so I know what, we're doing here and everything. But it would be good to kind of collaborate with others to kind of share their individual experiences in terms of treating that.
Dr. Kotiah, do you have anything to add to that? Dr. Del
I
Rivero?
have not had one. So it's all
Great. Okay. Dr. Del Rivero, if someone has symptoms of MEN1, genetics are negative, and hyperparathyroid adenoma is still not removed, should they only remove the adenoma or 3.5 glands?
That's a great question. And usually the recommendations is for a patient with MEN1 and primary hyperpara is to do 3.5 parathyroidectomy. And that's the indications and the recommendations because there is hyperplasia of the four parathyroid glands. So each one of us has 4. So there is hyperplasia of the 4 of them. And also the MEN1 gene is in every cell in your body. Even though they may say, well, we only see a 1, the other ones we don't see it, it's going to be there. And eventually you're going to have more adenomas causing primary hyperpara. So the recommendation is to do 3.5 parathyroidectomy when that happens.
Great, thanks. Dr. Lee, I know you also see lung nets. There's a question that came in about why experts don't talk about arterial blood gases for lung nets, and would these tests reveal any information? Why they're not part of the regular workup?
So unless like you would only get arterial blood gas, and this is not again specific for neuroendocrine tumors, but for any patient seeking medical care, is if the oxygen saturation is really, really low, that's the only time you would potentially get arterial blood gas. To be able to get arterial blood gas, you're essentially putting a needle in terms of your artery in the wrist and everything, and that causes a lot of pain. I can tell you that. So I don't think you want to routinely be getting that because that's not going to provide you any additional information unless you're really, critically sick and everything, and it's just going to cause you a lot of pain.
Yes.
Great. And another question about symptoms, Dr. Del Rivero, is example photos of jaundice and flushing tend to be of white or light-colored, light-skinned people. And is this often missed as a symptom in dark-skinned people of color, jaundice and flushing?
Jaundice and flushing. Jaundice is usually kind of like a yellowish discoloration. Even in patients that have really dark skin that we cannot see it, we can still see it on the eyes. We can still see it under the mucosas, like under the eyelids. And so we can still see it. It's a very classic, jaundice, signs that we can also see it on the eyes, even if somebody has very dark skin that we cannot see it. Now, in terms of flushings with somebody that have dark skin, it's a little bit harder to see visually visually. However, flushing also comes with symptoms, right? It's not just the flushing that you see it. They also feel like these warm feelings, the palpitations, the anxiety. It's a whole syndrome that comes with the flushing as well. That I feel like even you're unable to see it, we still ask the same questions, and we kind of like assume, even though we don't see it visually, that these patients may have flushing, just the way the patients feel.
Great. Dr. Kotiah, do you have anything else to add, Dr. Lee?
No, I mean, I think what she summed it up pretty well.
Okay, great. And there's another question for you, Dr. Del Rivero. With the NIH Natural History Study, are you studying those who had their tumors surgically removed and currently have no evidence of disease?
We're actually following both patients that had history of neuroendocrine tumors, because one thing that we wanted to understand is because it's a longitudinal study, we study patients for long periods of time. We also wanted to understand, once a tumor is resected, how, what is the likelihood that it may appear later on, what is the timeline? And so those are the things that we're also trying to study. But we also see the more advanced disease and patients that had received or they have resistance to other therapies. We're studying all neuroendocrine tumors. So this is a study that includes all neuroendocrine tumors, no matter what the stage are.
All right, great. Dr. Lee, we kind of talked about PRT and follow-up scans and treatments. There was a follow-up question for a patient who had PRT and say completed in June of this year, hasn't had scans since their pre-PRT gallium in December 2019, scheduled for a follow-up gallium in December 2020. Should they have a CT or MRI? Because you kind of mentioned both. So the question is really about whether a CT or MRI with follow-up imaging post-PRT.
I think it just really depends on what imaging that you got at baseline and throughout the course, because comparing MRIs to CTs is essentially comparing apples to oranges and everything. So you want to be able to have a direct comparison. So whatever anatomic imaging that you have had most recently, during that treatment with PRT, that's what you want to be able to match up on, or else you're not going to be able to read too much on at least this set of scans that you get. So maybe even this set of scans might be your new baseline scan to assess and on which to compare moving forward.
Okay, great. There's one person who asked the question, this is our second to last question, why can't a pancreatic NETs be removed with surgery? So Dr. Kotiah, what are reasons that PNETs cannot be removed with surgery?
So it's more of a surgeon question, but usually the reason why you wouldn't be able to remove any kind of pancreatic tumor, not just a PNET tumor, is if it's wrapping around major blood vessels, and they can't sort of free it up, or if it's metastasized and there's too much of a liver burden to debulk, or the surgeons feel like they can't meaningfully remove most of your disease. I mean, and again, that's a controversial thing because not everybody believes in liver debulking. I think the neuroendocrine surgeons definitely believe in it, but not all institutions believe in doing debulking. But just to sort of focus mainly on the pancreas, it would be mainly because it's sitting in a location where the vessels can't be reconstructed, or the vessels are going to be compromised. I don't know what my colleagues will say, but that's usually for me.
Yeah. Thank you. Can I comment on that? Just because that's kind of like one of the things that every Thursday we have our tumor board, and we have all this. We have the endocrine surgeons and we have the hepatobiliary pancreas surgeon as well in this meeting discussing the cases. And it's always indication when to do surgery, and also and whether it's multiple or solitary. So it's also about depending on size as well. If the neuroendocrine tumors, a pancreas neuroendocrine tumors, is less than 2 centimeters in size, and they already underwent an endoscopy and is well differentiated neuroendocrine tumors, maybe you want to watch it now, because the likelihood that this is going to grow rapidly is very low. So you may want to watch if it's less than 2 centimeters in size. Once it reaches 2 centimeters in size, so the indication is to do surgery. But now the question is, like, a lot of our patients, one patients, they have multiple pancreatic neuroendocrine tumors. They may only have one, they have multiple. And what are the risks of benefits of doing such an extensive surgery, having multiple, pancreatic neuroendocrine tumors? And those are the things like, well, we can watch it because they say, depending on what is the age of the patient, what is the longevity, what is the comorbidities, all of the things that we keep in mind to really determine which patients you kind of like weighs the risk of the benefits of doing such an extensive surgeries when you're about to do Whipple's procedures, when you're about to do this extensive surgery. So I think those are the things that we need to keep in mind. That's why, as Dr. Kotiah said earlier, this is kind of like a multidisciplinary treating neuroendocrine tumors. It has to be discussed in a multidisciplinary team with surgeries, radiation oncology, and so forth, because that way we can definitely have all the information and have a better understanding how we can approach these patients. But it's also size is important to know. Sometimes we just watch it, and if greater than 2 centimeters, then we can say, okay, we can do surgery because the likelihood that can go to other places is higher. And then, and the question is there are multiples like we see in MEN1 or VHL? What do we do in those situations? And that's kind of like the risk of benefit. And there is a study, I think Dr. Lee and Dr. Kotiah know about using an embryo tie. Could that stop the growth? And so sometimes we just use embryo tie in those patients so that way we can slow down the growth of these tumors, just because maybe for that time surgery may not be indicated for those patients. Yeah.
Good point.
Dr. Lee, do you have anything else to add? That one?
No, I agree. Depends on size, and then obviously extensiveness of the surgery. Because if you're doing a large Whipple, then potentially you're putting someone as a diabetic, for the rest of their life. So that's something that you have to consider. Generally for us, yes, 1 centimeter or less, definitely don't do anything. Over 2 centimeters, probably have to have a discussion on risks and benefits of surgical resection. And then 1 to 2 centimeters, that's a controversial area. So you can read about our thoughts based off of our review that we published recently. So with JCO, so it's a very controversial area. So
right.
But I had a patient who had like a pancreatic neuroendocrine tumor that was the same size for like 12 years. I mean, so I think what Dr. Delver is saying is also true, that you can monitor some of these patients. Some of them might never ever need surgery, and that's the thing that's challenging about neuroendocrine tumors. I mean, they say that the risk of lymph node metastases is lower if your tumor is less than 2 centimeters, and I guess there's some controversy Dr. Lee is alluding to. But like you don't always, you're right, you don't always have to rush into surgery.
Well, we'll just take this last question. And I think that, as you're all aware, right, this has been a really hard year for everyone. And then today we're especially recognizing the NET community. And thank you, all three of you, for celebrating with us today to help increase education and awareness. So in honor of NET Cancer Day, what would be the biggest takeaway you'd like to share with those of us affected by NETs, patients, caregivers, those in the community? So Dr. Lee, we'll start with you.
So I think with NET Cancer Day, it's really about awareness, raising more awareness for neuroendocrine cancers, and I think we've come a long way as a community in terms of raising that awareness. I think we do have to take it a step further. So it's not only necessarily raising awareness, but as I mentioned before, we have a lot of these potential innovative therapies that are going on that we're trying to bring to our neuroendocrine patients and improve their lives. But at the same time, like you mentioned, it is somewhat of a difficult year, and for our community, we are still somewhat limited based off of the resources. So I think what I want to encourage all NET patients is not only to raise awareness in terms of the diagnosis, but take it to the next step. Be able to advocate, not only for yourself in terms of your care on a daily basis, but now start to think about how you're going to advocate in terms of the future development of treatments that can potentially impact your life. So what does that mean? There's been a lot of clinical trials that have been designed, but they might have been designed without necessarily your full input. And particularly on this day, where we have come to recognize that every single vote counts in this country, what I want you to do is potentially to go out there and say, talk to the investigators that are investigating in the research and say, why did you not build this into your trial? Because what we've struggled with in neuroendocrine tumor research is that we have all these trials open, but a lot of the trials actually don't go to completion. And part of the reasons why is because they didn't take the input, right? One of the reasons why, let's say, the cabozantinib trial is struggling, it's a great trial, but could they have done something with patients and patients could have voiced them to them from the very beginning and said, you need to have a crossover arm no matter what, or else we're not going to go on the trial and everything. that could have solved things a lot from the very beginning, rather than potentially putting this trial on jeopardy that possibly could, really have a positive impact on patients' lives. So take that step further and say that your voice really does count. And we've been able to see that today. And talk to the investigators, talk to your community, and say, we're going to dictate how we're going to be able to change our lives one step further.
That's really well said. And thank you for, really encouraging us to have a voice. I know, Dr. Lee, you've always been like that with myself, with Giovanna, with the LACNETS community. Thank you for that. Dr. Kotiah, what would you say?
I mean, I want to say that one of the things that I really enjoy about neuroendocrine community in general is the fact that there is a lot of collaboration with the patients, and a lot of discussions where the patients are involved and they're supporting each other and supporting us. And that's kind of unique to neuroendocrine tumors, as opposed to other cancers, apart maybe from breast, where there's a lot of support groups. And I think it's great to continue to build patient centers and patient support groups, because we need more of them. I've been trying to build one in Baltimore for the longest time, and they haven't launched away from my hospital, but it makes an amazing difference when you have, and yes, it is still a rare cancer, to have other people who've gone through it and gone through the journey can help you, because that's a life-changing thing, a game changer is what I was going to say, that to be able to reach out to the people who've gone through it and feel like you're not lost. And the other thing I want to say is, not to lose the forest for the trees, we as physicians, we're focused on, treatment, moving treatment forward, moving neuroendocrine care forward, just like you are as patients. But don't forget to live your life. I mean, it's good to have knowledge. It's good to be aware. It's good to be informed always. And I think that we, as a younger generation of physicians, we want to be in discussions and help make decisions together versus trying to tell you what to do. Because like Dr. Lee was saying, your input matters a lot into how we move forward. But, like with all things in life, whether you have a metastatic neuroendocrine tumor or a breast cancer or lung cancer, I can't imagine living with metastatic cancer is a whole different ballgame. And I think it takes a lot of courage to sort of push aside your worry and live your life and make sure that you're maximizing your quality of life and make sure that you're not forgetting to enjoy the things around you. And I think when being an oncologist and watching people through their journey, it's taught me to appreciate my life and my health and the fact that none of those things are guaranteed. So, and it's great that if you have caregivers, because, having a caregiver is very, very, uplifting for a lot of patients, because it makes them feel that there's somebody in their corner, just like their doctors are in their corner, the support groups are in your corner. But, I really just, want to make sure that we don't stray away from, yes, there's treatments, there's things, there's decisions to be made. And that's always going to be a time point where you're going to have to make a decision. But don't forget in the middle to push it in the background and don't let the cancer take over. You're in charge. Your life is up front and center, and the cancer can walk behind you. And then when you have to bring it out and deal with it, you deal with it then. That's the main thing I want to sort of say to the neuroendocrine patients.
Thank you for saying that. That's really well said. So instead of just focusing on how long we live and how to extend that, how really to shift that focus to how well we live. And thank you for caring about that. Dr. Rivero, what would you have to say?
Oh, wow. So I have to say it's very difficult to, after Dr. Lee and Dr. Kotiah, is so difficult to top everything that you guys say, because I do agree with you. And that's very inspirational what you both say, and very true. But something that I wanted to say to patients and the NET community is that we understand your hurdles. We do understand. We understand the difficulties that you're going through. That we understand that sometimes you need to travel long distances to see somebody who has this NET expertise. You feel isolated, you feel alone, and we understand your struggles. And that's something that us as a NET community, we're trying to, help you with that. And I think that organizations or support groups just at the LACNETS, and I have to say, Lisa, you've been doing a wonderful job bringing us together. I think that you're bringing everybody together. And I know that you're also following the dream that Giovanni had. So I think that's something that we wanted to continue her dreams and continue what she wanted to do in her life. She wanted to advocate for each one of you. She wanted you to fight for this disease. She wanted you to stick together and move forward together. And I think that the NET community, you're doing an amazing job. And that's something that I think the patients needs to be aware of, this, that they're not alone. We are together in this journey. We are together with your journey as well. And we are going to fight with you no matter what they are. We are going to fight with you all the way. And we're going to be with you all the way. And that's important. And that's why being together with with you and Dr. Lee and Dr. Kotiah, that also tells me like we are such a close community that we care so much about each one of you. And that thing that's very important. And I just wanted to say that, it's something that I have said in my talk as well, and that's something when I met Giovanna, because I happened to meet Giovanna in Barcelona at the NETs meeting, and we have this cooking class together. And I was actually next to her the whole time, and I took a picture of her, cooking the paella. That she was such a giving person. All she was doing is because of all of the people that were living with NETs. It was just amazing. And that was a time when I came with a quote that whatever you do for you, that stays with you, dies with you. Whatever you do for others and the world will always be immortal. And that's why Giovanna is going to be immortal all around us, because that's what you wanted to do. And with that, I have to say that, again, you're not alone in this. We're fighting with you, and we are in your voice count. And I completely agree with Dr. Lee, your voice count. For any clinical trial designs, for anything that we are doing in advancement, your voice count. And you need to speak out, because we are the ones that we need to listen to you in order to move forward. And without you, we cannot advance. So we need you. We are in all of this together, is all I want to say.
Amen. And I loved the quote that you ended with, the end of your presentation. Individually, we're one drop. Together, we're an ocean. We feel, I want to say on behalf of the NET community, we feel all your care and support, all of you, Dr. Lee, Dr. Kotiah, Dr. Del Rivero. One way is, right, the time you took on the presentations today, the time you took 2 hours with us on the Q&A to answer everyone's questions today, very thorough response, all the work you're doing behind the, both clinically and behind the scenes of clinical trials, all the research presentations, all of this that you do, so that we feel that, not just that we're not alone, but we have a team fighting for us, supporting us. So on behalf of the NET community, LACNETS, and all of us in the community, patients, caregivers, everyone alike, thank you, Dr. Lee, Dr. Kotiah, Dr. Del Rivero, for taking this time to celebrate NET Cancer Day with us. And with that, this concludes our Q&A session. Thank you very much.
Thank you.
Thank you. Thank you so much.
Thank you. Thanks, Lisa.
Join us for the 2 remaining educational programs in 2020, including on November 17th on high-grade neuroendocrine neoplasms, and on December 8th with Michael Echelon from the Simsmans UCLA Center for Integrative Oncology. Check out our website for our other programs as well, including our virtual support groups, including our NET patient support group, our caregiver support group, NET Vitals, and health coaching, as well as much, much more. And I'll let you take it away, Lindsay.
Again, as a reminder, patient advocacy groups are an important source of NET news and resources, so we encourage you to sign up for our newsletter on our website and follow us on our social media pages. You can find us on Facebook, Instagram, Twitter, and YouTube. Speaking of YouTube, today's live symposium is being recorded and will be up for your viewing pleasure on the LACNETS YouTube channel in just a few days. We will also be sending out a post-symposium survey shortly. We would greatly appreciate if you took a few minutes to share your honest feedback with us. And before we say goodbye, we would like to thank our sponsors, Ipsen, Sun Pharma, AAA, and Tercera. And again, thank you to Rich at TVP Live for making today's live broadcast possible. Thank you for tuning in, everyone. Have a wonderful rest of your weekend. We hope to see you again soon. Goodbye.